Já estamos, Roberta, no ar?
Ainda não, doutor. Eu falo ao vivo aqui.
Ok.
Pode. Valendo, doutor.
Ok. Boa noite a todos. Gostaria de agradecer a participação e a presença de todos nesse webinar, que falará sobre controle de sangramentos, o que nós temos de novidades e atualizações sobre o assunto, um tema de muita importância para os profissionais que trabalham na área de urgência e emergência, assim como de trauma. Good evening. Thank you for everybody who's watching our presentation today. This webinar sponsored by Hospital Moriah. Then we're going to talk about bleeding control. I would like to thank you all my invited guests to be the speakers and the panelists. It's a great honor to have you all here. We're going to start the first presentation by Dr. Paula Ferrada, who's going to talk about circulation first. Buenas noches a todos amigos de Latinoamérica. Vamos a iniciar nuestra presentación con doctora Paula Ferrada hablando sobre circulación primero y después seguimos con doctor Juan Carlos Duchesne y doctora Megan Brenner. Muchas gracias a todos por la participación. Paula, it's with you. Okay, let me open our presentation. Can you see our presentation, Paula? Okay.
Okay, I cannot see the presentation. Can you please share it?
It's not there?
Nope, it's not. I cannot see it. While Dr. Ribeiro places the PowerPoint, there it is. I want to thank Dr. Ribeiro for the wonderful invitation. It's a privilege to be here today talking to all our Latin American colleagues. Thank you so much for the opportunity. What we're going to talk about in the next few minutes is has the time come to question the ABC's priority of trauma? Should we talk about circulation first instead of airway first in people that are exsanguinating? Next, please. I have nothing to disclose in the sense that nobody's paying me to give this talk. Marcelo, press next.
Yeah, I'm trying to find where I can do that. Oh, yeah, here.
You just do a bar. There you go. Nothing to disclose. Next. We all had this patient that is hypotensive. This patient is bleeding out when we're seeing trauma, especially the one that we see in the places where all of you work in Latin America, Brazil, Colombia, Ecuador. They're victims of penetrating trauma. They're not bleeding slow like the patients that have blunt trauma. They're bleeding fast. They bleed, those wounds bleed with personality, 1 liter per minute. What does the patient do physiologically to protect him or herself from dying? Next slide, Dr. Ribeiro, please. So the first thing that happens is that the patient starts gasping for air. And then when the patient starts gasping, that increases, or in Spanish is called jadeo. I don't know how it's called in Portuguese. The gasping brings the blood from the veins into the heart, increase venous return. Then on top of that, you have vasoconstriction. That's why we all have noticed that our trauma patients come with diastolic hypertension. It's not that the blood pressure machine is broken. It's that physiologically is what's happened to stop the patient from bleeding, to increase the blood supply to the brain and to the heart. Next slide. And then what happens when we intubate the patient? So that increases the blood supply to the heart, increases the cardiac output. Next, what happens when we intubate the patient? Number one, we paralyze them and we sedate them so there's no more gasping. Number two, all the vasoconstriction that they're trying to achieve in order to avoid death goes away and they become vasodilated. And if we haven't killed them yet with those two things, the next thing that we do is that we give them a positive pressure ventilation, and that kinks the IVC acutely, decreases the cardiac output acutely, makes the patient hypotensive. And all of you that had experience with this, with somebody that comes with multiple gunshot wounds that are like pale diaphoretic and saying, I'm going to die, most of them, you intubate them, and you find yourself now rushing to open a chest and clamping the aorta, or rushing to provide some sort of proximal control. Next slide. We looked at VCUR experience retrospectively. We presented this as a quick shot for the American Association for the Surgery of Trauma, and we looked at hypotensive patients that retrospectively that got either intubation first or some type of circulatory support first, either blood pressures or clamping the aorta simultaneously or before intubation. Next slide. And when we compare the people that had airway first, 75% of them died. And then 78% of them died. Now, the people that have some type of support of their circulation, 50% of them died. Mortality is super high, not because we don't know how to do trauma in VCU, but because these people come in super sick and they have a very high mortality anyway. Most of these patients dropped the blood pressure as soon as anesthesia was given. Next slide. So since then, we decided that we were going to do a multi-centered retrospective trial to evaluate what was happening, if this was even feasible, and what were people doing outside of VCU. We did a retrospective analysis of hypovolemic shock patients from January 1st of 2014 to July 1st of 2016, and we collated the data in demographics, timing of intubation, vital signs before and after intubation, and the blood transfusion, as well as the outcomes. Next slide. We found from 440 patients that met the inclusion criteria that 55% of them received intravenous product resuscitation first, and or some type or plasma or blood first before they were intubated, and 44% were intubated first. Because this was a retrospective review of patients, then sometimes we found ourselves comparing apples to oranges. It was not great data, but in the data, at the very least, what we found, and we couldn't prove that there was a difference in mortality. Mortality was the same, but at the very least, we could prove that people were already thinking about it and already doing it in people that were exsanguinating. So what should we do? Next slide. What should we do to the exsanguinating patient then? I can tell you that, Marcelo, next slide, please. I can tell you that if I was having somebody that was bleeding and I want them to give them the best chance at survival, will be either simultaneous or before, give them some support before you go ahead and intubate and take away everything that they have in order to compensate for the hypovolemic shock. Next slide. The American College of Surgeons have figured this out somehow. When we have somebody that has a gunshot wound or a stab wound that is bleeding rapidly with a obvious vascular injury, we don't secure the C-spine first, or we don't intubate the patient first. We pack the wound, we put a tourniquet, and that campaign created by Dr. Jacobs was called Stop the Bleed. Most of you have had some training on this. This is not where you don't start the primary survey by asking any other question other than the name and stopping the bleeding before you do any other resuscitative maneuvers. Next slide. So can you open the chest and clamp the aorta before the ET tube is in? Yes, you can. I have done it. Not easy, especially with a moving patient, but can be done. I think for patients we have now a tool that will allow us to do this in a patient that is awake with a lot less tissue in between you and and your object of compression, which is the aorta, which what now is basically REBOA. Next slide. Is basically a stop the bleed, a big tourniquet that is applied in places where your tourniquet cannot be applied. It's basically a thoraco-abdominal tourniquet. So let's do a couple cases. Case number 1, Dr. Ribeiro, next slide, and then next slide. This case came with multiple gunshot wounds. It was in the right thoraco-abdominal area. And we decided we were going to take him to the operating room because he was maintaining the airway, gasping for air, as is expected with somebody that is rapidly bleeding. Blood pressure, first was 80 systolic, second was 60 systolic, the next one couldn't be measured, weak pulses, still talking. It was we placed a REBOA, and as we were intubating at the same time. Next slide. The first blood pressure that we got after the balloon was inflated was 80, which was better than non-existent before. We opened the right chest, found that he had a pulmonary artery injury, turned the lung, got proximal control and repaired it. Open up the abdomen because there was a gunshot wound so diaphragmatic injury, gunshot wound to the abdomen. The blood in the abdomen was not enough to explain how sick was the patient. And then afterwards, once we were in the ICU, now we had the opportunity to take a look at the labs showing a pH of 7.01, INR 2.3. Patient was coagulopathic at the time, but we resuscitated him appropriately 1-to-1 with not too many crystalloids. Closed the abdomen, day number 2, extubated day number 3, and left and without any further issue. Next slide. Case number 2 is. And I understand that, not in many places people use REBOA. It's actually not that hard to learn. Dr. Brenner, I'm sure, is going to give us a very detailed lecture in when to place it or not to place it. And I understand that the use of this tool in penetrating injury is controversial. I also think if you have different tools in your armamentarium, you have to think twice between open a cavity that is not going to directly help you stop bleeding on a patient that is deteriorating, and then what are you going to do with all the muscle and all the skin and everything that is bleeding after the coagulopathy? Okay, this is another case. 38-year-old male, multiple gunshot wounds in the extremities with tourniquets, weak pulse but no blood pressure. REBOA was placed, the blood pressure returned, then he was intubated. Exploratory laparotomy showed a liver laceration, and he also had an injury to the popliteal. I think the liver laceration was a grade 5, and there was about 5 liters of blood in the abdomen, so enough that was the reason why the patient was bleeding. But I think we were able to avoid a resuscitative thoracotomy in this patient. I think. Next slide. We have right now in the future, what are we doing? We're doing a prospective trial. It's not randomized, but it's prospective, in which we're following what are we doing for exsanguinating patients. Next slide. And basically seeing the hemodynamic differences that patients have once you resuscitate them first in some shape or form, preferably with plasma, then blood, platelets if you have them in that order, and see what the outcomes of these patients are. I'm sure Dr. Duchesne is going to give us a fantastic lecture in euvolemic hemostatic resuscitation. Thank you so much for your time and for the invitation. And are we going to take questions now, Marcelo, or at the end?
Wait, can you hear me? Yeah.
Yeah.
See, I think you have to go, right? Because you have something to do.
I do,
so
but I can take a couple of questions if you have them.
Yeah, let me see if we can get some questions now. Otherwise, we try to talk with people that have questions. I send it to you later. Don't worry. Roberta, eu preciso saber se já tem alguma pergunta para a doutora Paula sobre a apresentação dela, para que ela possa responder, porque ela vai precisar fazer outra atividade agora. Temos alguma pergunta? Okay, so let me see. Carlos, you want to do some questions for Paula before she leaves? Please.
Well, yeah, I think it's great. Thanks for the opportunity. It's a great presentation, Paula, as always. I just wanted to, I think physiologically, it's a very nice concept, and it's very adequate. And I think the prospective trial that they're doing with the AAST is going to give us some good results. That's interesting. I wanted to ask her, in her extensive review and knowledge of the field, there are a couple of papers that I found There's one, they're basically in the military, based with the Battlefield Advanced Trauma Life Support. It's what we call BATLS. There are some papers that, focused on this similar approach in the military. So I just wanted to know if she found useful this focus or this knowledge that is from the military, also in the civilian setting that we're seeing right now. And I'm sure that she's had a chance to review those papers from the Royal College of Surgeons. One is from Sapford and the other one is from Hodgetts. So I just wanted to know if she had some insight about that. Thank you.
Carlos, let me see. I think Paula just disconnected. I'm sorry, but we're going to make sure we have these questions asked, sure, and then we can share with the audience later on. I would like to kindly request for everybody, by the time you're speaking, please open your, so people can see you making the questions, okay? Is there any other comment? Dr. Ordóñez, muchas gracias por su participación. ¿Tiene algún comentario respecto de la charla de Paula sobre los sangrado primero, control del sangrado primero?
Hola, buenas tardes, ¿cómo están?
Muy bien, Carlos, muy bien. Mucho gusto verlo.
¿Qué más? No, nosotros también creemos lo mismo, que tiene que ser primero el acceso arterial y venoso antes de la intubación, porque hemos tenido ya varios pacientes, escribimos un artículo también con Paula, en que demostramos que si intubamos estos pacientes antes de los accesos, los pacientes se tornan hipotensos y no somos capaces de sacarlos adelante. Entonces estamos tratando de que todo sea casi simultáneo, no intubarlos en urgencia, sino que sea muy simultáneo al mismo tiempo. Si les tenemos que operar o les tenemos que poner el REBOA, casi al mismo tiempo la intubación. Y así hemos logrado eso, pero no la intubación en un paciente grave en shock. Creemos que no se puede porque se colapsa y después es muy difícil sacarlo. Entonces yo creo que estamos haciendo todos parecido y vamos como en la misma línea. Ese es el comentario. Yo creo que está muy bien ahí vamos, todos vamos en esa línea, creemos.
Mucho bien, muchas gracias, Carlito. Yo voy a hablar un poquito en portugués. I'm going to speak in Portuguese to make a summary of the Paula presentation, guys. 1 second, please. Então, para os colegas que chegaram agora na reunião, os que estão nos assistindo pelo YouTube, das considerações mais importantes feitas pela doutora Paula Ferrada, no paciente grave, com choque hipovolêmico grave, vítima de trauma, atualmente considera-se, antes mesmo da intubação, se iniciar o tratamento do sangramento, e isso nos Estados Unidos tem sido feito com a colocação do REBOA, que é um catéter endovascular intraótico, que a doutora Megan Brenner vai falar na apresentação subsequente, assim como acessos venosos para reposição volêmica com derivados de sangue. Uma vez que os estudos demonstram que o paciente sendo intubado, paciente muito grave e crítico, sendo intubado para depois se proceder à correção da letra C, esse paciente tende a fazer uma hipotensão como um reflexo da intubação, e com isso tem o seu status hemodinâmico ainda mais agravado. Juan Carlos, let's move it on. You ready for a presentation, you think?
Yes, I'm gonna try. I'm gonna see if let's see if we can get to my screen. I changed computers, so let's see. Okay, this is new. I have something that looks like it's working. Hang in there.
All right, let's see it. Yes, it is.
Okay.
Yes, perfect. It's here.
Perfect.
Thank you so much, Carlos, for participation.
So I'm not sure the videos are going to run, but I apologize for that. But I'm going to go ahead and start the presentation. So I'm going to be speaking about strategies in damage control resuscitation, what's new. And one of the things that I want to point out is that in order for us to make a difference, we need to change the way we think, and we need to think out of the box. And that's the only way that is going to help us get better with resuscitation. This is a study that we will be presenting at the AAC this year. This is the opening presentation for AAC this year, where we are going to be talking about 800 MTPs that we analyzed, where basically we haven't changed mortality after 10 years of MTPs in a BC level 1 trauma center. The mortality have been very, very steady. So I'm not going to give you more information because I will be stealing some of the information for AAC, but definitely something to pay attention, and I think we can do definitely better if we decide to move the pendulum. All right, so this was a video. Unfortunately, it's not running, but it's a trauma patient that came in very sick. And the question is, when you have somebody with so many injuries exsanguinating in the OR, what is the best way to resuscitate this patient? So many of us, we like to stop the hemorrhage, obviously in the operating room, in the ER, or sometimes even in interventional radiology. So it's definitely a big team effort that will make a difference in stopping the bleeding in this group of patients. So bleeding patient life is on the clock. Time is life. Every second it passes, the patient has a higher increase in mortality if we don't resuscitate them aggressively. There's been varying techniques in how to stop the bleeding, going from the use of tourniquets to the use of whole blood to the use of level 1 infusers. And with new technology, we've been basically trying to stay away from trauma resuscitation with crystalloids. And I think that that's something that is from the past. And like Paula was mentioning, in this group of patients, the key component is to establish circulation first. And it's not what kind of circulation, because in our trauma center, we've been reviewing for the last 2 years the impact of just giving crystalloids versus blood at the very beginning as the initial mode of resuscitation. And there's a major difference between both study groups. So when you have a patient that is exsanguinating, you need to give the patient what the patient is exsanguinating, blood. This is a nice picture that was sent to me back in 2009. We were when we started all this process of trying to do one-to-one resuscitation. This is how the OR looked like with a bunch of crystalloids. And I think now in 2019, 2020, we're going to be moving more and more with the use of whole blood. So this is a classical description of what happens when you're exsanguinating. You are very, very dry. Many of you guys know where this is in France, where basically where the tide goes down, basically everything looks very dry. So that's just like a trauma patient. When they're hemorrhaging, they're very dry. And the key component here for to establish a better outcome is to give the patient blood or any kind of component therapy, whole blood or component therapy. This is the study that Paula referred to, which I'm going to skip because she basically mentioned that there is no difference in mortality between circulation first versus airway first. Also, there was a little trend in survival benefit when circulation was achieved early. This was a video. I'm not sure. I cannot promise it's going to be running, but basically this video, oh, there you go, a video that works. Perfect. So this is an animal model of exsanguination where the animal is on the vent, and this is the contractility curve. And once you disconnect the animal from the vent, you guys can see how much the amount of contraction in the heart augments. And so it's obvious and it's very dramatic. Just the impact of positive pressure in the chest diminishes the amount of contractility in the heart. So just imagine when we do this in our trauma patients thinking that we're doing the right thing, we're not. These patients need blood. This patient needs effective volume, not a vent. So because of that, we need to make sure that the patients receive what they need. Let's load up the tank. Let's give them what they need, blood and not just crystalloids. And this is a classical slide that I basically like to present. I've been presenting this slide for many, many years now, where the 4 fluids of life, you guys can see from when we are babies to Coca-Cola to Budweiser and then crystalloids. That doesn't hold true anymore for hemorrhage, because when you give all these crystalloids to people that are exsanguinating, that edema, that volume goes into edema, creating more complications. And because of that, we're going to now talk about the evidence behind the effective resuscitation. All this endeavor started back in 2006 to 2008. We were the first civilian trauma center that actually demonstrated that by giving one-to-one resuscitation to our civilian casualties or civilian patients with severe hemorrhage, the mortality went down to 26% compared to 88% when the ratio of blood to plasma was not kept at 1-to-1, but rather it was 1-to-4. So a lot of work over time have evolved, including the PROMPT study, the PROPER study that specifically look at platelets ratio. And a lot of people have been involved in trying to get the right ratio for our patient. And I think that at this point, people advocate for a 1-to-1 to 1 to 1 to 1 to 2. And we basically demonstrated that these strategies of damage control resuscitation can definitely increase the likelihood of survival in patients that are in extremes. This is a nice study that now everybody's trying to pay more attention on the pre-hospital arena. And this is a no-brainer analysis where they look at the impact of giving blood in the pre-hospital arena compared to patients that did not receive blood. And obviously the patients that received blood, the probability of mortality was way lower. Again, no rocket science, common sense. This is the one of the landmark studies published in 2018 regarding the PAMPER trial, where basically they document, Jason document that by giving plasma early, patients actually survival benefit differentiation to the ones that didn't survive. It starts as early as in the first 3 hours. So whole blood, is it here to stay? It's a good question. We're not sure if the whole blood is the right answer. I'm going to be honest with you. And I'll be presenting more information, hopefully in the future. But this is basically how whole blood is being categorized. You can store it for 48 hours if it's fresh and transfused on the spot. If it's within 21 days, it is basically stored with CPD and CP2D. And CPDA can store up to 35 days. Obviously, keeping in mind that this is stored at 1 to 6 degrees Celsius. Now, keep in mind that 1 unit of blood to plasma to platelets do not stand for 1 unit of whole blood. Please take a quick look at this presentation where you can see that the hematocrit difference is dramatic between 29 versus 38 to 44%. Platelet count is dramatic. So a lot of things are not the same. So it's a very bad concept to even think that 1 to 1 to 1 is the same as whole blood. It's not. So this is how patients used to look in the past in our trauma center when we basically gave the 1 to 1 to 1. Now we're giving more whole blood, and we just finished a randomized controlled trial. We are basically, I'm going to give you a little bit of information. This is our first patient that received whole blood after GSW to the abdomen and pelvis with initial systolic in the 60s. And he was extubated after massive transfusion. He was extubated the same day and actually sent home by day 5. Very good case. And this is, you guys can see the lactic acid getting fixed on the spot immediately once we start giving the patient what he was bleeding, and he just received whole blood. So I don't want to say that whole blood is the cure of resuscitation. There's a lot of things that we need to keep in consideration. When we have patients with exsanguination and we start giving whole blood through a rapid infuser, up to 500 cc's a minute, you can have devastating consequences. This was a case where a patient received a total of 4 units of whole blood, 2 liters, within 3 minutes. Just imagine what I just said. That's a lot of volume. The patient unfortunately developed TACO, transfusion-associated cardiac overload with massive pulmonary edema. He survived, but it's some of the things that we need to take into consideration. Look at the difference between the volume of 1 unit of PRBC to the difference of the volume in a unit of whole blood. Big difference. We are about to, we actually submitted to the Southern Surgical Association our first abstract regarding whole blood in our single institution randomized controlled trial, where we compare whole blood utilization to balanced component therapy. We had a total of 249 patients total. And I don't know if you are happy to hear this or not happy to hear this, but there's no difference in mortality. And we need to be cognitive of that. What we demonstrated actually is that the patients that received whole blood had less utilization of ventilatory days, less time in the ICU, less volume of component therapy, and less incidence of utilization of massive transfusion protocol. So there's a benefit in the use of whole blood, but there's more to come. So obviously, all these techniques that we've basically been describing over the years, they can work when done effectively. And REBOA is one of them. And Megan is going to be talking about the use of REBOA. I just wanted to introduce what we learned from 2 big data sets on patients that we analyzed on the impact of the delta systolic blood pressure. This was just published in Shock, and I urge you guys to take a good look at this analysis. What we wanted to know is, as you guys can see on this CAT scan, this is our REBOA in place in the aorta. And the question is, what REBOA numbers is telling us? What is the meaning of those numbers? When you have a patient that is sick, and you're giving MTP, you're giving tranexamic acid, low volume resuscitation with hypertonics and whole blood, what else can we learn from this kind of patients? So this is the classical patient that I received, where this is where I started questioning, what is the benefit of knowing the change in that initial systolic blood pressure? This patient came in with an initial systolic of 60 systolic over pulp. We put the REBOA, and the first manual blood pressure came up to 100. By the time we connected the patient to the REBOA A line, the blood pressure was 127. That's a dramatic increase in systolic by more than 40. So my question was, what that number means. So we decided to do a big data analysis on what is the definition of that delta systolic, what is the impact of knowing what is that number. So we look at a bunch of patients, and we basically stratified the ones that did not recover from hypotension, defined as less than 90 systolic, were classified under non-responders from initial blood pressure. The ones that actually from initial blood pressure less than 90 that went over 90 were classified as responders. And what we identified is that the patients that had a delta change, a change in systolic, initial pressure to after REBOA placement of more than 40, those patients had a better survival advantage. So that number is telling you something. Not only that, the patients that were non-responders, most of them, when they died early. They died in the emergency department or in the OR. So we need to develop some kind of a risk stratification that will tell us if your delta systolic is less than 40, you need to start moving fast. That means that all the strategies that you have in your armamentarium, meaning blood resuscitation, immediate transfer to the OR, those things need to start working fast in order to basically increase the survival benefit of this group of patients. This is, I did an internal audit on our trauma center for the last 9 months. And we identify, as you guys can see, you need to identify who are your super users. And obviously, to my surprise, I was not in shock that I'm one of the super users. I've done 21. I had 1 mortality. And what we identify from our preliminary analysis is that the more REBOAs you do, the more actually good you get at it. And not only that, you start placing them in not dead patients, but rather in patients that you know you need to buy some time to put to get the patient to the next level of care. So we talk about REBOA, we talk about whole blood. Just very briefly, I just want to talk about minimization of crystalloids. When we are dealing with patients that are in severe hemorrhage, it's very important that we give the patient what they need. We need to give them blood and minimize the amount of crystalloids. This was a nice study that we had a couple of level 1 trauma centers cooperating, and we had a total of 200 that received more than 10 units of blood in the OR. And we analyzed the impact of crystalloid volume in that first 24 hours. And what we analyzed is that also most of these patients received the amount of packed red blood cells with an increase in the amount of crystalloids. The amount of plasma described in yellow went down. So that was very interesting because not only that, the patients that received more than 5 to 10 liters of crystalloids during MTP had a 4-fold increase in complications. So stay on top of your MTP, but at the same time, make sure you're minimizing the amount of volume of crystalloids. Try to stay less than 5 liters in that first 24 hours. So low volume resuscitation is definitely important. This was another study where we look at the impact of hypertonic saline after, in the first 48 hours after hemorrhage control in damage control patients versus lactated ringer solution. We had 2 set of patients, 76 in the hypertonic arm, 112 in the lactated ringer arm. And as you guys can see, most of the patients in the hypertonic saline arm did better in regards of inflammatory response and in regards of outcomes. Not only that, we prove as well that patients that receive liberal use of lactated ringer in the first 48 hours, those patients had a higher amount of intake with less output, and the group that was managed with hypertonics had less intake with way more output, making them more negative way faster. So fluid restriction in the trauma ICU plays a key role in the management of these patients. This is how it looks now in our EPIC medical record notes, where you guys can see this is in red on the left. You guys can see how much blood this patient received immediately upon arrival, and in the first 48 hours, the patient was managed with MTP followed by hypertonic saline and 5% albumin in a low volume resuscitation mode. After that, the patient is HEP locked and they're on tube feedings only. That's it, tube feedings only. And this patient, that's the way that we should be taking care of this patient with severe hemorrhage. It is extremely important that if you're not doing this, you need to develop some kind of a tracking system that you look at volume overload as a fallout on quality care for this kind of patients. And if you, over 48 hours, your amount of volume overload is more than 10%, you need to start restricting the amount of intake in this group of patients. It's being clearly demonstrated that this group of patients actually have a higher risk of renal failure. So those are some of the things that I think in the future we're going to be changing. So a case for life. Time is life, and life needs blood. Make sure that when the patient is bleeding, make sure you give the patient what they need. Today is a whole blood day. That's one of my nurses put that when we started the whole blood randomized control trial last year, and because they knew that we were making a difference. I just want to show this two videos very quickly, and I think that trauma resuscitation is changing, and it's changing dramatically. This is a model that in an animal model of full exsanguination cardiac arrest. Full exsanguination cardiac arrest, no pulse. The patient has a catheter that is placed just like the REBOA and is supplying diesel to the catheter, oxygen, and in blood. And in this model, actually, they're basically preserving the amount of perfusion to the brain and amount of perfusion to the coronary arteries. And from full cardiac arrest without chest compression, with this use of this catheter, I think we're going to make a difference. This is still in an animal model. This has not been deployed in the typical civilian trauma centers, but I think we're going to be learning very soon of a difference in this way, in the way we manage these patients. Last but not least, I think that as many of you guys know, I think that the key concept here is if we're going to do something different, we need to start changing the mentality of patients with severe injuries. From basically going to the hospital, in the hospital, going to different areas in the hospital, maybe to the 3rd floor, to the 4th floor, to the 6th floor, to get CAT scan, to do trauma resuscitation, to the ICU, to the OR. And I think we need to change that mentality and start managing the patient in the ER when they arrive to the ER. This is a real case scenario from our friends in Japan. 5 minutes from arrival, this patient in the emergency department, they get a full CAT scan. And on the CAT scan, they were able to immediately see what problems the patient was having. So immediately the CT of the head, no visible hematoma, multiple rib fractures, bad pelvic fracture with extravasation, meaning there's something to do. So now the team knows that this patient needs to be in a resuscitation mode, meaning we need to protect the airway. We need to get the patient what it needs, blood resuscitation. We need to stop the hemorrhage. We need to start thinking about placing a REBOA. The patient needs to have REBOA, and at the same time, he needs to have volume resuscitation with blood components. So this is a quick image of the team putting a REBOA within the first 18 minutes of arrival. And as you guys can see, it's in Zone 1 deployment, bad pelvic hemorrhage. They're getting ready for a preperitoneal packing, 28 minutes from arrival. And they did the preperitoneal packing. Putting hemostatic lap pads inside the cavity. The patient's systolic is in 140. This patient is being well resuscitated at this point. And after doing REBOA, doing preperitoneal packing, reducing the volume of the pelvis with a pelvic binder, they're going now for an angiogram embolization of the site of bleeding. So many thanks to everybody for allowing me to indulge in your brain on how much better we need to do in the field of trauma resuscitation. Thank you so much.
Juan Carlos, thank you very much. Amazing presentation. Very helpful for us to understand the way to go now, from now on. Unfortunately, in Brazil, we still do have a lot of problems to have whole blood. Some places are trying to start it, but we still have a lot of difficulties with the hematologists and the blood banks. And I think it's a reality in most of the places in South America. I believe in Colombia is not a problem any longer, as far as I know, but in many other places it's still a problem. So I would like to open if you don't mind, to stop sharing your screen, so we can invite the other panelists to talk about this. Tercio, would you please give some comments on that?
Oh, yes, thank you, Marcelo. Congratulations, Juan Carlos. Great presentation. That's a new perspective, the whole blood, and how it has changed the way we deal with these severe patients. Very well showed, like we did before with crystalloids, and now whole blood with a good perspective ahead. And I agree with Marcelo. We have a lot of difficulties to do this in our hospitals. A lot of hospitals will try to do that, but a lot of difficulties. I have no experience with this right now. So because of this, it's great to hear from you about this. Thank you.
You're welcome.
Dr. José Mauro, would you like to please comment?
Yes. Yes, thank you.
Please open the video, if you don't mind.
Okay, now. Amazing presentation, Juan Carlos, and we know, we don't have a whole blood here in Brazil. And in your opinion, what's the best proportion of components of blood if you don't have a whole blood?
I think that's I think in my practice, as soon as it's a multifactor. One of the key things is that you need to keep in mind that if you're going to pull 1 unit of blood, that patient needs to receive tranexamic acid on the spot. That's in any patient we pull blood. I changed my modality of tranexamic acid. I don't give any more 1 gram. I give 2 grams on the spot, and I don't do anything else. I just load the patient up with 2 grams. That creates things more easier for the nurses. So once I do that, we basically try to match 1 unit of blood to 1 unit of plasma. And then I am more aggressive giving cryo up front in our patients. And by the time they're in the OR, we have basically 2 thromboelastograms. So the first thromboelastogram is when they arrive. Usually you don't do anything with that thromboelastogram because you are in resuscitation mode. You're not going to be waiting to see what the thromboelastogram says. So you're in full-blown 1-to-1. Then when they're in the OR, then you can see what the tracing looks like. And if the tracing looks like you're doing the right thing, then you just basically continue what you're doing and then target until no more blood loss. I use platelets based on thromboelastogram only. We actually discussed the use of platelets on 1-to-1-to-1 versus 1-to-1-to-2 many years ago, where Holcomb was the reviewer of my poster. And I remember Holcomb telling me, Juan, don't publish this. That's wrong. It's 1-to-1-to-1. And I'm like, but I cannot. I mean, that's not what my data says. So we didn't publish it because I was, I'm not going to piss off John. And it's funny that then the proper analysis and the prompt analysis came by and they document kind of the same findings in a better randomized control fashion, that 1-to-1-to-1, 1-to-1-to-2 is okay. And I think that's the things to remember.
Okay.
Thank you very much.
I will do some translation to Portuguese here. Então, uns comentários muito importantes da apresentação do professor Carlos Duchesne. A questão, um dos focos principais da sua apresentação foi o papel, a importância do sangue total na reanimação dos pacientes graves, vítimas de trauma, associado com outras modalidades terapêuticas, como o uso do balão endovascular, o REBOA, no mundo ideal, uma sala híbrida, onde você possa já fazer todos os procedimentos conforme foi demonstrado no vídeo, e o papel de realmente uma reanimação customizada para o paciente, e mostrando que realmente a possibilidade de usar o sangue total para esses pacientes já no início da sua admissão na sala de emergência fazem uma grande diferença. Infelizmente, no nosso meio, salvo algumas exceções, alguns lugares que estão se preparando para isso, no Brasil, infelizmente, isso não é ainda uma rotina. Eu vou rapidamente perguntar para o Dr. Carlos Yanez na Espanha e o Dr. Carlos Ordóñez na Colômbia, como é que está a situação do sangue total. Carlos Ordóñez e Carlos Yanez, como está a situação do sangue total em seus países agora? ¿Tiene disponible? ¿Tiene siempre? ¿No lo tiene?
Hola, Marcelo. Espérate. Quisiera preguntarle también a Juan Carlos. Nosotros en este momento ya tenemos casi listo para empezar la sangre total. Hicimos todas las pruebas, pero con lo de la pandemia se nos ha atrasado el proyecto. Entonces quisiera preguntarle a Juan Carlos si ellos quieren cambiar ya radicalmente el 1-1-1 a sangre total, o lo harían ir introduciendo poco a poco la sangre total. Y si es así, el paquete de trauma, ¿cuántas unidades de sangre total estaría dispuesto a tener listas para transfundir? Si 2 o 4. ¿Y qué tipo de sangre? Si es O negativo, O positivo, o cuál. Entonces, como, a ver, Juan Carlos, ¿en qué va en eso? Como preguntarle. Pero nosotros particularmente hemos tratado de adelantar todo. Estamos casi listos para arrancar cuando esto se resuelva un poco, pero ya tenemos todo el proyecto y todo para empezar, pero no hemos puesto todavía, sino simplemente ensayos.
Sí, es buena pregunta. Nosotros estamos utilizando O positivo en todos los pacientes, menos en las pacientes femeninas. que tienen edad de tener hijos. Esos son las O negativas. Eso es el único personas que se le da la sangre completa O negativa. Nosotros estamos ahora un año ya utilizando sangre completa y vamos a hacer un análisis interno. Y yo creo que lo que va a pasar es que vamos entonces a empezar a utilizar más y más sangre completa en cualquier activación de transfusión masiva. Hemos demostrado que en todos los pacientes que se utilizó sangre completa, la incidencia y de activación de la transfusión masiva disminuyó por un 20%. Y yo creo que eso es algo que motiva a las personas que están vigilando la calidad de tratamiento en los pacientes.
¿Cuántas unidades, Juan Carlos, le han puesto al principio? ¿Cuántas tuvieron que poner?
Sí, nosotros como estamos en un estudio randomizado, nos dejaron utilizar nada más que 4 unidades de sangre completa por paciente, que son 2.000 mililitros.
Bueno, interesante. Carlos, en España, ¿cómo es la situación de sangre total? ¿Se lo tiene, no tiene?
Pues sí, a ver, te comento, Marcelo, la situación en España en general y básicamente en el sur de Europa, la sangre total todavía no es una realidad en el mundo civil. Está comprobado el beneficio de ello. Yo creo que esto ya es alguna reflexión que siempre me hago, lo que hablaba antes, la importación, ¿no?, de lo que es el concepto del mundo militar. Pues realmente el uso de sangre total se remonta a la Primera Guerra Mundial y de hecho fue una de las grandes aportaciones de la Primera Guerra Mundial con el capitán Oswald Robertson, y se generó realmente los movimientos de bancos de sangre a nivel mundial, pero realmente en la Primera Guerra Mundial es cuando se comienza a utilizar transfusiones de sangre completa. Después de eso se deriva en productos por componentes y todo lo demás. Actualmente en Zaragoza tenemos 2 proyectos y en España, pero sobre todo en Zaragoza, que es donde estoy yo, donde estamos trabajando, es poner disponible, que te lo comentaba recientemente, poner disponible whole blood, pero a forma de walking blood bank, más que todo para mass casualties y en casos de uso militar. Y esto lo estamos haciendo con colaboración estrecha con el ejército. Y con respecto a lo que es la parte civil, y esto lo comento en inglés por si hay audience in English, it's we're using for the civilian trauma, we're using is our effort right now, more than giving whole blood, that I want to thank Juan for this great presentation. It's more, our struggle is to have a one-to-one component therapy available at the emergency room immediately for massive transfusion, because we don't have the same trauma profile that we have in Latin America and America. We don't have so much penetrating trauma. So it's a little bit different. So our effort in civilian trauma is to have one-to-one blood available in the emergency, in the trauma bay first.
Perfect.
Okay, guys, great discussion. So now I think we can move forward to Megan Brenner. She's going to talk about REBOA. That's a very hot topic as well. And then we can open discussions and talk more about blood transfusion and REBOA and everything else. Megan, thank you so much for being with me here in this meeting. You ready to go? Yeah, it looks like.
Can you hear me?
Okay, yeah, we can. Go ahead.
Okay, perfect. All right, thank you so much, Marcelo, for the invitation. This will be a quick review and update of REBOA as we're using it clinically, as well as hopefully some discussion afterwards. The following are my disclosures. So I'm going to touch on the clinical updates, how we're using it today in clinical settings, as well as traumatic cardiac arrest. Can't have a talk about REBOA without talking a little bit about complications and how we can mitigate those. Discussion about REBOA and penetrating injury, thoracic injury, how we're actually getting better with REBOA over time, how it's turning out in patients with hypotension from hemorrhagic shock, the rapid adoption that we've seen, talk a little bit about partial REBOA and new technology coming out, as well as briefly REBOA for non-trauma. So lots to cover. You all are familiar with REBOA at zone 1 for hemorrhage below the diaphragm and also for any patient in arrest. For REBOA zone 3 is for pelvic junctional or high extremity hemorrhage. It's placed just above the aortic bifurcation. Again, relative contraindications are severe vascular injury above the level of the occlusion. So essentially, REBOA provides normotension above the aortic occlusion in order to perfuse cerebral and coronary circulation, and provides very permissive hypotension below to reduce hemorrhage. So currently, we see it most often in trauma for hemorrhagic shock. Many more patients are receiving REBOA in zone 1 than zone 3. It is also being used in traumatic cardiac arrest due to hemorrhagic shock. A few instances, looking back retrospectively, that these patients actually come in were in neurogenic shock from high C-spine injuries, as well as cardiac events that occur in patients that end up coming into the hospital as trauma patients. In non-trauma, a litany of different uses for REBOA, as well as in non-traumatic medical cardiac arrest. So starting with the traumatic cardiac arrest outcomes, those of you familiar with the literature, Dr. DeBose published this, looking at a large number of patients who received resuscitative thoracotomy through the East CPG and compared it to his aorta database. And the bottom line was that over many years, we just don't seem to be getting better in how to treat these patients who come in with traumatic cardiac arrest and require resuscitative thoracotomy. So if we look at REBOA in the same database in aorta and compare it with resuscitative thoracotomy patients who receive an open thoracotomy with aortic cross-clamping, so they essentially meet the same indication as patients who receive zone 1 REBOA, breaking down into the patients that required CPR before the hospital or even after admission, but at the time of aortic occlusion, we didn't actually see any difference in survival beyond the ED or survival to discharge. This is just in this particular database, but we are starting to see some differences in survival in some of the other databases. So this is a recently published article about pre-hospital CPR and early REBOA. This is from the ABOT Trauma Registry, 26 patients in 11 centers throughout Europe and Asia. This is not pre-hospital REBOA. This is REBOA in patients receiving CPR in the hospital. Almost half had return of spontaneous circulation on arrival, and of those patients, 42% of those survived. So remember, this is patients that have ongoing CPR on arrival to the hospital and receive REBOA. Also, about half had no return of spontaneous function, and only 14% of those survived. So looking at the ones that had return of spontaneous circulation arrival, not surprisingly, higher survival rate for those. The risk-2 score predicted their mortality of 0.97, but it turned out that there was a 27% overall survival rate to hospital discharge, so certainly significantly higher risk-2 score than was predicted. We looked at total cardiac compression fraction in end-tidal CO2 at shock trauma and looked at the fact that it's certainly higher in REBOA patients than aortic occlusion patients, and the reason is really can boil down to one photo. And this is while the REBOA is occurring, we are getting constant cardiac compression, whereas during ED thoracotomy there is a certain amount of time where the chest is open and there is no cardiac compression occurring. So the graph here really depicts blood pressure as a function of time. The gray areas are continuous CPR. The white areas are pause of CPR for pulse checks, and the black is aortic occlusion. So REBOA is occurring through this whole time. Aortic occlusion occurs, and we see an immediate rise in systolic blood pressure, as well as many other variables. End-tidal follows this pattern. The end-tidal CO2 between 10 and 20, even with high-quality CPR. After aortic occlusion, it just continues to increase. We looked at 33 patients and 18 aortic cross-clamping patients. The ROSC was higher, not surprisingly, in the REBOA patients. They survived to operative intervention more frequently. Not surprisingly, again, as we saw in the graph, end-tidal CO2 was higher before and after aortic occlusion with REBOA than with resuscitative thoracotomy. REBOA patients had a greater total cardiac compression fraction, which means that they were undergoing cardiac CPR more often than the patients that were getting resuscitative thoracotomy. And there was no difference in hospital mortality for both of these groups. When we looked at the first 60 uses of the new catheter several years ago, shock trauma and UT Houston, we pulled our results together and found that about 60%, again, seeming consistent with the other literature, 60% of these patients are achieving return of spontaneous circulation. 40% of those survived the ICU. The survival for blunt total traumatic cardiac arrest, about 9.5%, which is still on the higher side for, again, blunt cardiac arrest, and a 40% survival for our patients who were victims of penetrating injury and were in traumatic cardiac arrest. So for use of REBOA in this situation, it's really about understanding your resources and your goals. So a lot of people talk about, it's just not worth it. These patients are dead. The survival is dismal. So the downside is, yes, these patients are surviving out of the ER. In some institutions, mortality rates are based on location. So if you die in the ED, it doesn't count against you. If you die in the OR or elsewhere, of course, it hurts your mortality rate. Some people say it prolongs the inevitable. It's very, very resource intensive, which is very true. So depending on your institution, that might not be something that's amenable to you. And of course, there is a cost associated with REBOA, but also with resuscitative thoracotomy. So the upside, I would say, it's potential organ donation. We've seen many patients receive great organs from patients who have received REBOA and actually lasted long enough to at least get up the ICU and be amenable to organ donation evaluation. It gives time for the family to come to the hospital. Again, these are not banner outcomes necessarily, but having the family be able to make it to the hospital, talk about goals of care. There's an emotional factor there that we can't measure. The team also gets to build experience with with these skills. Obviously, training and skill sustainment are a big issue with REBOA, especially in those who don't have a lot of experience with endovascular techniques. Again, as I mentioned, no talk about REBOA is complete without talking about complications. We can see anywhere up to 30% of the following complications. They are listed in most every publication about REBOA. This is systemic complications. We're starting to see a lot more, again, with increased use, up to 30%, especially hitting the kidneys and the lungs most significantly, as well as cardiac, overall end organ, as well as some endocrine deficiencies after REBOA. So these are the three, I would say, the three top picks for references if anyone's interested in looking at specific publications discussing the complications of REBOA. Marcelo wrote the middle one. The one on the bottom, that's a really great discussion about the actual metabolic derangements following REBOA, and there's a lot of literature, a lot of interest in trying to mitigate these complications. So speaking about complications, obviously they mostly occur due to the duration of aortic occlusion, right? We're causing massive ischemia distally. So in order to try and circumvent this, the joint statements from the COT, ACEP, NAE MSP, and NAEMT put together a publication that came out last year, just really recommending that zone 1 should not be used and aortic occlusion should not occur for more than 15 minutes without the patient moving quickly to the operating room or someplace where definitive hemorrhage control can work. Duration of greater than 30 minutes is obviously associated with increased ischemic complications and mortality in zone 1. For zone 3, there's not a lot of data about the complications in relation to duration of aortic occlusion, but for zone 3, the aortic occlusion target range would be somewhere between 30 and 60 minutes. And again, this comes from unpublished data, opinion, and extrapolation from some of the non-trauma aortic occlusion data. Mitigating the organ injury, which occurs with duration, prolonged duration. There are some great data about lower extremity cooling, 4 hours of zone 3 REBOA, decreased ischemic muscle injury, and lowered compartment pressures following reperfusion. This was in a translational model, so we're not sure whether it would apply to humans, but it's certainly a great start. the same group took a look at esmolol in order to reduce myocardial injury, which is induced by REBOA, again in translational effort, and it can certainly mitigate the effects of REBOA on the heart. And then a lot of discussion and publications regarding partial REBOA and the ability to provide partial flow in order to mitigate the ischemic process which occurs with prolonged aortic occlusion. So moving quickly, just onto REBOA and penetrating injury. Having spent many years in Baltimore, definitely got the timing was perfect. The violence increased as we were becoming more familiar and more comfortable using REBOA. So it was almost like the stars had aligned a little bit. But we took a look at our combined effort, as I mentioned before, with UT Houston, and took a look at our penetrating patients, both those that were in arrest and came in and were not in arrest. The survival rates were quite surprising. 40% for survival for those patients who came in with penetrating injury and who were in traumatic cardiac arrest. There was also 100% survival for those patients in penetrating arrest who received REBOA, who were not in arrest. And again, if we look at these numbers, these are extremely small numbers. If we want to take a look at penetrating injury in REBOA, we need to look no further than this group of great individuals who have really kind of pushed the envelope with this. Penetrating injury is something that they are exceptionally well versed in. One of their first publications about REBOA and mortality in penetrating trauma patients. Within probably a very short period of time, they had 28 patients that they used REBOA on who had suffered from penetrating injury, and they used a propensity scored matching system in order to evaluate the risk-adjusted odds of mortality, and they found that REBOA actually gave these patients a better chance, certainly at survival, according to the propensity scored matching system. The most recent publication, they described the use of REBOA for penetrating chest trauma. Again, not very long did it take them to reach 56 patients. 66% of those were penetrating trauma, and 81% of those suffered gunshot wounds. So this is almost the opposite, literally the opposite from what our experience here in the U.S. in terms of ratio of penetrating with blunt injury. 24 patients had thoracic injury, and of those, 87% were penetrating. So again, this group are just pushing the limits forward, pushing the envelope in terms of REBOA, and really helping us understand whether this is a viable option for thoracic hemorrhage and penetrating hemorrhage. So they found that the survival rate of patients with thoracic injury treated with REBOA was actually similar to the predicted survival percentage. The complications, again, they were at least as low as most of the current published US data. The biggest difference, and I'm sure many of you who have listened to Carlos speak about this, the REBOA occurs in the operating room, so this is a little bit different than we do in the US, where most REBOAs occur in the ED. But the REBOA happens in the OR with open surgical proximal control. So there's an amazing ability to make this work. And I think there's a few reasons. One is that clearly his institution is committed to treating severely injured patients. We're at a time when resources are scarce and actually being taken away from trauma, but certainly not there. They have two specific OR teams. So when the REBOA occurs, there's one team for just the REBOA and one team who is performing open surgery, access to the chest, and proximal control so that REBOA can be used as a resuscitative measure. Immediate OR access is also, of course, absolutely critical to make this work. So I do want to congratulate them as well for the short occlusion time. So, the average mean occlusion time was 35 to 40 minutes in this series, really helping to certainly improve outcomes there, especially mitigating complications from aortic occlusion. So congratulations, Carlos and your team. I wish we could congratulate you in person, but until then, it'll be a virtual cheers until we can meet again. So looking at some of the translational models, also suggesting that REBOA is possible and useful for thoracic hemorrhage. This is a swine model of blunt thoracic injury. The investigators found no change in size or density of pulmonary contusions with REBOA. They did find a blunted systolic blood pressure increase. Usually we see anywhere from 40 to 60 millimeters of mercury increase, but they were not able to see that. That was the only difference there. Another very recent translational REBOA paper just published looking really at zone 1 REBOA and how it did not actually significantly affect short-term survival or thoracic blood loss in swine with thoracic hemorrhage. So in specific situations, specific clinical scenarios with experienced users and specific institutions, REBOA is certainly safe for use in the setting of thoracic hemorrhage. And we look forward to seeing really a lot more publications, both from both the clinical side and translational research, helping us to navigate this, this new area for use in REBOA. So I mentioned there's some data talking about how we're improving over time. Joe DeBose published this in JVTM recently, looking at the small and large sheath, introducer sheaths and how they may relate to outcome. The 7 French system over, through the aorta registry showed that we're actually needing to cut down less. I think that's both a function of experience, training, as well as ultrasound use. That increased significantly, and the reduced time from AO to admission. So I think our patient selection is getting a little better. We're also deciding to use it earlier in the hospital course. He also found decreased blood product usage within the first 24 hours, as well as improved survival and reduced distal extremity embolism rates from 20% to 5.6%. A lot of that I do believe is due to the sheath size, but we can't exclude patient selection as well as experience over time. We looked at our shock trauma data and took a look at the newer devices with the smaller introducer sheath. Not only did it decrease procedural time, but survival also increased. Again, I do believe that is multifactorial and not just a simple function of sheath size. Another recent publication about just improved survival using REBOA. So this is, as we all know, our colleagues in Japan have been using REBOA since 2004. So they looked at their very, very early outcomes and compared them to their late period outcomes and found that REBOA patients are surviving a lot more now than they did in the early days. And that's even after adjusting for many characteristics, injury severity, and choices of hemorrhagic control. So again, is it provider comfort, patient selection? Is it technology? Most likely a combination of those 3 things. So some additional clinical updates. A propensity scored analysis just came out last December, talking about how REBOA is associated with improved survival. The survival to discharge was higher among patients treated with REBOA than those without. Again, a propensity scored matching analysis. And then this we presented at AAST last fall, comparing complications and investigating complications at zone 1 and also zone 3 from the aorta trial. We found that age greater than 55 is not a contraindication to REBOA. I think that's one of the first times we've actually been able to elicit that conclusively. And aortic occlusion greater than 90 minutes at zone 1 showed a 3.8 time increase in access complications. So really going back to mitigating and reducing the maximum duration of aortic occlusion in order to reduce complications. I'm not going to belabor this. Juan did a fantastic job of the overview of his paper. As you saw, the mortality was higher in the non-responders, and the non-responders had a lower median pre-insertion systolic blood pressure, something we had thought was probably happening, but he and his group definitely proved that with his study. Another group, our friends in Sweden, took a look at the outcome of REBOA in patients with impending traumatic cardiac arrest and found that almost 40% of the patients survived if REBOA placement was successful. So a lot of additional data coming out. These are 2 studies from UT Houston. The interesting part here about the catheter distance and balloon inflation. There's a lot of different recommendations in terms of insertion inflation lengths. But what they found was that it's actually extremely variable. Zone 1, the inflation, anywhere between 8 and 19 cc's, zone 3, 5 and 15. So there's not one specific centimeter mark that you can insert to each patient or a number of cc's to inflate for aortic occlusion. You really have to do it individually, and external marking is extremely important still for the placement. The PRI-time prospective observational trial is in press currently in Annals of Surgery. This is the 6 U.S. trauma centers who were enrolled in this trial. There were instances or observations of procedural time, real-time procedural time data collection, and that demonstrated that the procedure took less than 10 minutes, which is something we've seen. That also included getting access. ROSC occurred in about 50% of patients undergoing CPR. So again, this is consistent with the data that we have seen both from high volume single institution centers as well as multi-institutional trials. In terms of complication, there were only 2 amputations. Both patients had severely mangled extremities from the injury, and the access side was the opposite from that which required amputation, and there were 5 vascular repairs and no sequelae from that. A quick discussion about adoption. We all know that REBOA has kind of taken off at an incredibly rapid rate. Just looking back over the past few years, in the aorta trial, in 2013, there were 2 centers, a few patients. A few years later, 8 centers, 46 patients, and just 4 years later, we have 44 centers enrolled and 761 patients who received REBOA in the AAST aorta trial. So hopefully, we're going to get even more great information and great data that we can use to recommend clinical use for REBOA. Along with this, of course, goes with the adoption and implementation of new devices. Over the past 4 years, the REBOA came into the FDA approval in 2015, but started to be used really in 2016. And in 4 short years, 171 level 1 trauma centers in the US are using it, and 417 hospitals total. So the company has also come out recently with a device that looks very similar to the current REBOA, but it provides partial REBOA, so partial occlusion. The balloon itself looks very similar. It's a little bit longer. There's a safety valve, which basically, if there's any, as the balloon gets close to maximum pressure, the release valve, the safety valve, will deploy, and the balloon will not be able to be inflated any longer. This is in order to reduce the balloon ruptures that were seen initially. The catheter itself, if we look at the axial view, so this is the balloon, and you can see that there's channels all around the edge of the where the aortic wall would be. So this allows some partial flow down into the distal aorta. This is, again, just newly FDA approved and will be available in a limited market release at first. So it's going to be a little bit of time before we see this clinically and start using it and get some data as well. But in the future, hopefully there will be some smaller profile balloon catheters, which basically is going to allow us to use smaller introducer sheaths. These will come most likely as significant cost savings. There may be different lengths available for zone 1 and zone 3 occlusion. There's a lot of discussion and testing about different confirmation for placement, radio frequency, TEE, mobile forward-looking infrared. There's many publications regarding ways that we can use technology to confirm placement other than X-ray. So REBOA for non-trauma, unfortunately not time to go over any of these, but certainly REBOA is being used for all of these different entities, and there are publications for those. The only one I want to touch on, because it is a new, relatively new publication, our colleagues in Norway have been able to successfully place REBOA in 10 patients who were out of hospital medical cardiac arrest. So again, these are not trauma patients, just cardiac arrest patients. The mean age was 63. Almost all of them had successful cannulation attempts on the first time. They were all ultrasound guided. They used a 7 French sheath, but it's an over-the-wire balloon catheter, so slightly similar to our own REBOA. The end tidal CO2 was what they marked, what they used as their variable for resuscitation, was significantly increased pre and post REBOA, which again we've seen in the literature in the trauma patients. Again, we see this 50 to 60% ROSC becoming a consistent theme in the literature. 3 patients actually survived their hospital admissions, and one survived discharge to home. So there is certainly good physiologic evidence, lots of translational research to support use for REBOA in non-traumatic medical arrest. Animal data certainly suggests increased ROSC. REBOA is only a bridge to definitive therapy in this situation as it is in trauma. And complete occlusion times will most likely need to be less than they are in trauma. Obviously, if you have a patient who's in cardiac arrest and has a significant cardiac dysfunction, then aortic occlusion for a prolonged time is unlikely to yield anything remotely close to a good outcome in that patient, but trials are certainly ongoing, and we look forward to hearing the results of those. So again, relative contraindications, these are just recommendations for use as we have evaluated the literature so far. If shock is caused by major thoracic great vessel, cerebrovascular, or upper extremity injury, not likely, again, to work out well unless you have proximal control. You're in the chest, you have proximal control and exposure, either with you can clamp or even place a balloon, but certainly access to bleeding vessels that are above the level of aortic occlusion are key. Probably not useful to use REBOA if significant delays to hemostasis are going to occur. Not recommended to use it if you've not received training, and then also definitely not recommended to use REBOA in a place where you do not have access to definitive hemostasis, as well as a place that can handle all potential complications of REBOA. So it may improve survival and be superior to traditional methods of hemorrhage control. Outcomes are improving over time with use. We see that it can be used safely in ages over 55 years. It's currently used in hemorrhagic shock as an adjunct for trauma and non-trauma applications. We know limb and life-threatening complications have been reported with use, and technology training data as well as patient selection will aid in successful implementation and adoption of REBOA. Thank you.
Thank you, Megan. Thank you very much. Amazing presentation, a very nice overview of the topic. Thank you for mentioning our paper, because you helped me to make it work. And then we're going to open discussion here. Carlos Ordóñez, sus consideraciones, porque creo que usted tiene una de las más grandes experiencias en Latinoamérica.
Hola, hola Megan, gusto en saludarte. ¿Cómo estás?
Hi, Carlos.
Hi. Yo quisiera hacer un comentario y que Megan, a ver después, Marcelo, tú le traduces.
Okay.
Nosotros hemos entendido ahora, en este último tiempo, el REBOA como un nuevo actor en la resucitación, en la reanimación, cuando decidimos dividir unos cirujanos para operar y otros para manejar el REBOA. Entonces, no solo lo convertimos en un catéter simplemente que ayudara a controlar el sangrado, sino que ahora lo entendemos como, no es un catéter ya, es un actor fundamental porque tú lo pones, le das perfusión al corazón, al cerebro y vas bajando el balón, lo vas manipulando durante toda la cirugía. Entonces, y lo hemos encontrado como un nuevo actor fundamental tanto en la resucitación de control de daños como en toda la cirugía. Y entonces, quisiera que tú le explicaras a Megan, ella entiende porque está escribiendo un artículo con nosotros para que ella dé como la perspectiva de eso. Entonces yo creo que es fundamental no solo venderlo como un catéter que hace una cosa, sino como es algo grande, nuevo en la resucitación.
Yeah, okay. Yes, so Megan Ordóñez is talking about the importance of dividing the team in actually two teams, one to take care of the REBOA, that is not only a catheter, is more than that, it's like a very important tool during resuscitation, and the other team doing the surgical procedures, everything. So makes the team work a much better outcome for the patient. So, and this is a very smart idea, actually. The one problem we have in Brazil right now is that we're still waiting for, the paperwork to be approved in the Brazilian Anvisa. That's our national CDC, whatever. But we hope to be able to use it in a very short period of time. Estoy hablando con Megan que los problemas que tenemos aquí en Brasil es que estamos hasta ahora aguardando por la liberación de los productos en Brasil, por la agencia de regulación. No sabemos cuánto tiempo se va a llevar. La cosa es que están todos locos para hacerlo, pero no tenemos la liberación del gobierno. Entonces, ese es un problema. ¿Cuántos centros están haciendo REBOA en Colombia ahora, Carlos?
No, solo hacemos nosotros en los dos hospitales que tenemos en Cali.
Okay.
No más, no. La tenemos en la fundación y en el universitario, pero no más.
No más, nada, no.
Todavía nadie quiere empezar, nadie se atreve.
Okay.
I learned really quickly when I visited Dr. Ordóñez and the group that hospital, it's a very special place. It's very different than many hospitals in Latin America. It's very different than many hospitals in the US because we don't even have two surgical teams that we can dedicate to saving these patients. So the model there is just, it's phenomenal. And I really applaud them for, for taking the initiative to really demand better for their patients and get these resources because it's clearly working. Their outcomes are great. So
it's very nice. Yeah, I've never been with Ordóñez. Tengo que visitarlo. But okay, Juan Carlos, do you want to have comments on the topic of REBOA?
I think that one of the key aspects, also we do a lot of REBOAs. I feel like we are doing better. One of the key aspects is to get those late adapters to finally start doing REBOAs. And I'm going to be honest with you, I have really some hard-headed senior faculties that it's impossible to get them to do REBOA. And I showed them the numbers. I showed them, there's complications. So we're very open about the complications. But I think that what Megan demonstrated in that train, that huge jump, that's very rewarding. And I think that it's going to be more exponential in the next 4 years. So, but I think that the key concept here, maybe this is maybe me putting this out there. I think that the American College of Surgeons to make a better effort in not stratifying this technique away from ATLS as an example. I think that many of the surgeons out there have too many different silos of educations. And I think that they need to condense all these silos into one big silo, demanding the basic understanding of tourniquets, the basic understandings of REBOA, and then just have one license instead of having 6 licenses. So I think that that's my 2 cents on the political aspect of this.
It's one big stop the bleed.
Yeah,
it is. It is.
We changed the whole concept of hemorrhage control in this last 10 years, whatever, 15 years. So it's really hard to split it up. I mean, it must be all together.
Correct.
Que hablamos que los cambios de conceptos de manejo de sangrado tiene tanta cosa nueva en los últimos 15 años que ahora es muy difícil hablar de control de sangrado, REBOA, sangre total. Las cosas son todas juntas. En el futuro creemos que vamos a tener una única habilitación de control de sangrado que va a envolver todos lo manejo de REBOA, lo manejo del sangrado cirúrgico, todo una cosa solo, porque la verdad es que es una cosa solo, esa es la verdad. Son muchas herramientas, many tools that come together, que van a trabajar juntos para salvar a los pacientes. Carlos Yanez, ¿alguna consideración? Any comment?
Yeah, first of all, I want to congratulate Megan for such a wonderful overview and talk, and felicitar a Carlos Ordóñez también por su contribución en Latinoamérica. Es un pionero y persona que admiro mucho por su trabajo. We have it, we're starting it, we're wannabes, we don't have that much. We have it available maybe in big cities, starting now in Barcelona, Madrid. We're starting with a program in Zaragoza. One of the things that we're trying to do, gaining experience from Carlos Ordóñez in Colombia and from Tal Hotter in Sweden, is to do first multidisciplinary teams and do first an educational effort to create real teamwork, because it's not only a device, it's not only a technique that one person can manage. I like that aspect that Megan mentioned, that you have to be able to avoid complications and to treat the complications. So we're having first we're having a big training program nationwide, and that's going to come with credentialing. We have to credential the people that are going to do it, and we're trying to focus it more in a multidisciplinary approach for not only for surgeons but also in Spain for intensivists, gynecologists, and surgeons, because as you know, in Spain we don't have the trauma surgeon as such. It's more like a general, a GI, acute care surgeon. So that's the perspective that we're trying to develop in Spain.
Okay. Tercio, José Mauro, any comments?
Yes, good to see you, Megan. Great presentation. Congratulations, very complete presentation. Is there a relationship between the learning curve and complications, and number of patients that you reduce the number of complications with REBOA?
Thank you, Tercio. So we have looked really only at the numbers overall. We haven't, the first demonstration of that I think I've ever seen that specifically is what Juan had demonstrated in his chart. What we have to remember, though, is that everybody comes into doing REBOA with a different basic skill set. So some people have had a little bit of endovascular training. Some people have had none. Some people place A lines all the time, central lines. That skill is very similar. So we have to be really careful with, kind of controlling for all those variables if we're going to go and look at how many have someone done and what is the mortality, the outcomes for that. So that's something we haven't looked at specifically, within each institution, but we've certainly demonstrated with all the training that, it's something that can be picked up by an acute care surgeon that really has no endovascular experience. But I think, if Juan takes the lead on this and shows us that, the more we do, the better we get. That's certainly not a surprise, and something that's been published in the vascular surgery literature with the advent of endovascular surgery.
Hey, thank you. Congratulations.
Sí, Marcelo, yo quiero complementar la pregunta de Tercio. Es demasiado importante porque nosotros hemos visto eso. Cuando uno adquiere experiencia, sí puede lograr salir adelante, pero la gente que no tiene la experiencia o que no lo ha practicado comete errores muy graves, que uno es un paciente que se está muriendo y dos, o no lo puede colocar o daña la arteria. Entonces definitivamente lo que ha promulgado Megan durante todo el tiempo, que hay que hacer los cursos, que hay que practicar, que hay que estar encima de todo eso, yo creo que es sumamente importante y no podemos dejar eso como empezar. Tenemos que dedicarnos, y lo dice Carlos desde España, hay que hacer un grupo grande para educar a la gente, porque si no va a haber un boom del REBOA y de pronto van a ocurrir cosas graves, entonces tenemos que tener mucho cuidado con eso.
Gracias, Carlos.
So Ordóñez was telling about the importance of training people, really training people before they start doing. And this is something that really scary, especially like in Latin America. People get the equipment, they start using it. They don't really get too much concern about training. They just use it. You know, as long as the equipment is in the hospital, let's do it. So this is really, and this can be a dangerous toy. We all know that. We all know. Juan Carlos, we have a question for you from the audience, wondering if you have any experience using the whole blood in elective procedures at all.
No, I wish they would let me do it. Unfortunately, because it was set as a randomized controlled trial, they are not allowing us to use it in non-trauma cases.
Okay. Unfortunately, right?
But I do believe that there is the people in Houston, in Herman, they are using it right now for acute care surgery. So hopefully we're going to be learning more from that experience.
Great. Guys, I think we're just moving forward to the end. Before we finish, I would like to pay a tribute to a great friend of us who was just discharged from the hospital today after 75 days in the intensive care unit. This is Dr. Valdir Zamboni. Many of you know him. He's a well-known trauma surgeon from Clínicas Hospital in Brazil. An amazing friend, a rock and roll lover, and an outstanding man. As a human being and as a surgeon, he's alive, he's doing well, and he has been discharged after 75 days from the hospital. So I just want to pay this personal tribute to my great friend, Valdir Zamboni, who is now doing well and going home healthy, getting ready to go back to work. Peço a todos que se pongan las cámaras, please turn it on your camera. So now we take a picture. Kind of weird, isn't it? But vamos a hacer una foto. A ver, listo. Aquí estamos, aquí. ¿Qué tal? Okay, 1, 2, 3. Okay, so agradezco a todos. Muchísimas gracias por la participación. I thank you all for your time. Megan, thank you so much. You're such a great friend, and for spending most of your afternoon with us. And I know we're probably going to still have some work to do. I have to walk with my dogs, and I'm done for today. So thank you very much. Very, very nice to see you all doing well and healthy. And I hope in the near future we can get together again. Carlos Ordóñez, muchísimas gracias, mi hermano, por su tiempo, por estar con nosotros, por ser un gran maestro de la cirugía de trauma en Latinoamérica. Buenas noches a todos. Have a good night. And thank
gracias. You. Chao, saludos a todos. Un abrazo.
Thank you.
Yes.
Bye.
Chao.
Take care.
Chao.